Folks, the reason we're here is because we care about trauma outcomes. Trauma is the #1 cause of death in the first 4 decades of life, and for every life lost to major trauma, there are 2 victims who live on with severe and permanent injury. The chain of survival for trauma is different to that of out-of-hospital cardiac arrest. When I think about major trauma and the factors involved in trauma outcomes, it's far more complex. There are a lot more players in the major trauma arena. You look at those players, and many of them are providing excellent care in the islands in which they work. Okay? Superb care. But unless those islands are talking to each other, then that journey from roadside to recovery isn't optimized. The beauty of trauma audit and provided through a trauma registry is it gets those islands communicating, it gets those islands talking, it forces islands to talk. You see, a trauma system is an organised, coordinated effort in a defined geographic area that delivers the full range of care to all patients, and this is the key piece, seamlessly. And we've made strides in terms of, fundamentals of trauma care in this country, but we're not quite at that beautiful gold standard definition just yet. We've made huge strides in injury prevention. Our roads are much safer. We've made massive strides in pre-hospital care. We've made strides in acute care facilities and to a lesser extent possibly in rehabilitation medicine. You see, one of the problems that we've had is that we haven't been looking at the fundamentals that comprise our trauma system. We haven't been looking at the various factors that are associated with trauma outcomes. And the reason for that is that we haven't had a tool to do so with. This guy, William Deming, was a statistician who was part of the Japanese Industrial Revolution. He was involved with Toyota. And he famously said, you can't manage what you don't measure. And if we're flying into space, we want to be able to manage our space shuttle. And if I'm involved in major trauma care, then we need to be managing the care of that patient from the roadside to recovery. We can only do that if we're feeding data into a system, a dashboard system, a cockpit, whereby we can identify the factors that are associated with clunkiness or impediments to care, and we can celebrate those things that go well. But unless we know what's going on, then we have no way of being strategic about how we deliver care. And whether we're a trauma system in Uganda or whether we're a trauma system in Ireland, we need to invest in major trauma audit. I'm glad to say we are in this country at this stage. These are the other countries that are investing in major trauma registries and audit and have published papers on it. So the purpose of trauma audit and the purpose of audit in general is that we collect key variables so that we can risk adjust things to drive quality improvement. So what I want to do in Cork is be able to compare my trauma outcomes with Garrett's in the Royal London. Now Garrett's got a different trauma patient. He may have more stabbings or more gunshot wounds. I get a lot of blunt trauma. There's no point in me comparing my blunt trauma outcomes with Garrett's penetrating trauma outcomes. I need to be comparing apples with apples, so I need to risk adjust my trauma outcomes. Audit is key where we've got high cost areas of medicine with known variation in process and outcomes. And trauma very much fits that bill. It's very high cost, and it's particularly high cost if we create survivors who live on with significant injuries that they didn't have to live on with. Poor performance, again, poor performance leads to high additional cost and poor quality of life for those survivors. So the roles of major trauma audit are to monitor the care we deliver. We want to benchmark our care so that we're delivering the best care we can. We want to monitor our compliance with best practice. We want to see, are we getting those major head injuries into the CT scanner within an hour and into definitive care within a meaningful time frame? Are we adapting those evidence-based guidelines? Are we administering tranexamic acid where appropriate? We want to be able to see that, and we want to be able to see that real time because we want to be able to feed back to our people to say, there's a problem here, or well done here, okay? We want to be able to monitor equity of access. We want to know that that patient who has a major incident, major car crash down in Dingle gets the same level of care as that patient who has their car crash in Dublin 4. We want to be able to provide feedback to providers. We want to be able to say, well done, you had an unexpected survival. What went well there? Okay? Or we want to be able to say, look, you've got a lot of unexpected deaths there. You need to look at what's going on. These are the factors that contribute to the deaths according to the data that you're providing us. What can be done to improve things? We want to stimulate competition. I want to know that my hospital does trauma better than Pat Plunkett's hospital in St James's in Dublin, does trauma better than Dave Menzies Hospital in St Vincent's. Okay, I'm proud of my hospital. I want to make sure that my hospital is the best one. So we want to drive competition, and that's a fundamental component of a trauma registry and a trauma audit. So NOCA was established in 2012, and NOCA is the National Office for Clinical Audit. Okay? It's funded by the HSE and it's supported by RCSI, and it has, amongst other audit streams, taken on major trauma audit. Okay? And so TARN has come to Ireland, Trauma Audit Research Network. It's the biggest registry of trauma that's available in Europe. There's about 500,000 patients on it. I'm the clinical lead for its rollout in Ireland. It's self-funded through hospital membership fees, and it's clinically led, academic and independent. 21 of the 28 receiving hospitals in Ireland are now contributing data to TARN, and that's a great achievement, because up until this year we hadn't any idea as to what impediments there were to care, what our performance was like, what our outcomes were like. TARN collects data across the patient journey, from pre-hospital through to the emergency department, through to theatres, through to the rehab phase, from roadside to recovery. It's not dealing with the sprained ankle, the fractured wrist. This is dealing with the pointy end of trauma. These are the patients, the expensive patients, the patients that spend more than 3 days at your hospital, who are in your intensive care unit. And in return for that, we get feedback. We get epidemiological data around trauma, so we can prevent traumas happening in the first place. We get to look at our performance metrics, so we see how quickly we get that patient with major head injury to the CT scanner, how quickly we get into theatre, what the grade of clinician in the emergency department looking after that patient was. We get to compare them against gold standards, and fundamentally what we do is we compare our performance against others, okay? And that stimulates competition, and it stimulates us to sit up and be mindful and see what we can do to improve things. So my message is that to improve injury to recovery, to improve that journey for patients, we need a trauma system. And we need a trauma system because we know that trauma systems reduce mortality. And audit is the dashboard of the trauma system, and now we have that. Now we can continue to evolve our trauma system so as that we serve our patients as best we can.